knowledge as to how these patients behave when we have type 1 diabetes in adults. So we'll go step by step. First thing we'll see is the age-related genetic heterogeneity. If we see type 1 diabetes shows heterogeneity across broad range of clinical, genetic, immune, metabolic, and even histological features. Type 1 diabetes in children, when it occurs, it's much more having a HLA allele around in about 50%. It has a disease heritability. But when we talk about adult onset type 1 diabetes, much lower concordance rate in twins and less high risk HLA heterozygosity, more protective genotypes, and lower GRS. What is GRS? GRS is a genetic risk score. Basically, they assess the alleles which are there and they try to prognosticate as to this particular person has a higher chances, a higher risk of going into develop type 1 diabetes. Something which probably we don't have this facility in our setup well enough. Then, after going from the genetic, going on to the immune changes. So, adult onset type 1 diabetes is associated with presence of serum autoantibodies, with GAD antibody being the commonest antibody. The glutamic acid decarboxylate autoantibody is the commonest antibody which is present. Others can also be present, but in lesser cases, usually HLA-DR3 genotype is present. Multiple disease-associated autoantibodies would be less prevalent in adult onset and especially with an increasing age. Whereas, in contrast to childhood type 1 diabetes, insulin antibodies are very much present. The HLA-DR4 genotype is there, higher identical twin concordance, and more HLA heterozygosity and higher genetic risk score. So data suggests that type 1 diabetes is not that simple. We used to think कि ठीक है दो तरह की होती है type 1 which is an aggressive form which occurs in children where you require insulin. The others is a lower, less aggressive form which others occurs because of insulin resistance that occurs in adults. पहले हम ये NIDDM, IDDM करके करते थे. Then it was modified to type 1 and type 2. Now we realize that type 1 is there in a large number of patients which are probably being misclassified as type 2. So there's a heterogeneous across the spectrum of diagnosis, pathogenesis, even optimal therapy. Again, this was an interesting study of autoimmunity playing a role in the onset of diabetes after 40 years of age. So, in लोगों ने क्या किया कि they took in all the patients who had a high GRS, that is genetic risk score, by genetic typing, and GAD antibody positive. And then how many of them developed type 1 diabetes, and they found that 3.23 versus people who did not have these factors, in that it was 1.8%. So these combination of factors is definitely important in their higher chances of going to develop type 1 diabetes. So they may have what do you say other type 1 diabetes. If you talk about immunity, they have more adaptive immunity problems as well as the innate immunity problems. Innate immunity problems pathology is there in type 2 diabetes also, okay. But the adaptive immunity which involves the autoantibody cell activation is more so. But if we talk about the histological change in the pancreas, we don't have so many studies to validate and give us much information, and there's a significant knowledge gap. What about the other autoimmunity? Thyroid autoimmunity is present in around 38% of individuals with adults. I'm just talking about adults with type 1 diabetes. And celiac disease would be more often present when the IA2, the autoantibodies are present, then there are more higher chances of developing celiac disease. Now let's come to the metabolic characteristics. So metabolic characteristics, we know that other than the antibodies, we measure the C-peptide levels. So it is to be seen that C-peptide at the diagnosis is usually a little higher than in type 1 diabetes in adults as compared to type 1 diabetes in children. So C-peptide is also a little high, hence they may not require insulin at the outset. But we should remember that the C-peptide levels decline over a few years and the patient gets to require insulin quite soon. So we have to identify this group of patients. Now, correctly identifying this diabetes etiology is difficult, and misclassification occurs in as much as 40% of patients presenting with type 1 diabetes because of a lack of awareness. We know that we think that type 1 diabetes is only for children, so knowledge gap is there. That is one reason. Then, second important, Clinical criteria. We said that the BMI has to be low. They are thinner people. They are not obese, but these discriminators are very poor, as we know. And in the current scenario, obesity is very much increasing in the overall population. So they may be obese as well. So they masquerade as type 2 diabetes, and the progression is also relatively slow. And they have a superadded metabolic syndrome also. And we may not always have the accessing to the biomarkers like the C-peptide and the GAD antibodies. Probably that's why they misclassify very often. So then, what are the tools we have to distinguish them? We have the body phenotype is one important thing. If lesser BMI, then think about it. Though you cannot rule out in a higher BMI also. Look into the family history. Look into the clinical course. That is very important. The clinical course with the rapid deterioration and not responding to OADs is an important sign which should click in your mind that this could be an adult onset type 1 diabetes. Presence of autoantibodies, presence of comorbidities like hypothyroidism, celiac disease, etc., and the C-peptide level if required. And of course, the GRS is there, but it is not widely available in clinical practice for most of us. So what are the autoantibodies that we talk about? The insulin autoantibody is there. The GAD antibody is the most prevalent. Some may have insulinoma antigen 2, that is the IAA2. The zinc transporter isoform 8 antibody is there. And high levels of presence of any one antibody increases the likelihood that this could be type 1 diabetes. But we should remember that these islet antibodies can occur in patients without diabetes as well. So it is not always a clear-cut rule that if it is antibodies present means it is always going to be a type 1 diabetes. So then we should, this line is very important, that to avoid the false positive results, use high specificity assays and target testing towards those with the clinical features suggestive of type 1 diabetes. So first we should do this test only in patients whom we feel that this could be a case of type 1 diabetes too, only in them. If you do randomly, you will be very much confused and wrong interpretations may occur. Another thing, as the age advances, these antibodies may wane off and may be absent. So it may be an elderly, it may be a person around 40 years of age or 45 years of age may not have any antibodies, still be type 1 diabetic because with age they wane off. Then the second point is the C-peptide level paired with the blood glucose in the same sample. This is an estimation of the endogenous insulin production. But again, this is very confusing because always this will not be giving you the right answer. It is mostly useful when the levels fall below 300 picomole per liter. So this figure is important. If the levels are below 300 picomole per liter, more likely type 1 diabetes. If the levels are more than 600 picomoles per liter, more likely type 2 diabetes. And then again, we don't have clear-cut thresholds and categorically we cannot define. This is just an estimate which I'm telling you on the basis of various literature that I've gone through. So it should be interpreted with the context of other clinical and lab features. And another point, should we take a fasting or a random C-peptide? Always a random C-peptide is superior as compared to a fasting C-peptide for obvious reasons. In a fasting state, it is going to be suppressed. So after meals, if it gets stimulated, then that means that the pancreas are working good enough. The endogenous insulin production is there. C-peptide can be useful to guide therapy also. For example, someone has a C-peptide less than 300 picomole per liter, we should think of starting insulin immediately in these patients. If it is more than 300, then we could have insulin may be combined with other diabetes therapy. The could be is an important thing that the authors don't say that it try to avoid in this subgroup of patient in whom you are doubtful of type 1 diabetes. We would also not like to give SGLT2 inhibitors because there is a risk of decay with this in this particular segment of patients. So the other DPP4 inhibitors can be used. They may be used, but with caution. So the last line is very important that there is a loss of beta cell function in these patients and they should be closely monitored, and when required, insulin should be